Hi everyone, my name is Faustine Ramirez and I'm a master tutor with MedSchoolCoach for Step 1 and Step 2. And today we'll be reviewing a Step 2 CK cardiology question. So let's start by reading the stem. A 16-year-old boy presents to the physician's office complaining of fatigue, shortness of breath, and chest pain that occur during basketball practice. He also experiences dizziness when he is exercising vigorously and has almost fainted several times during practice. He denies cough, wheezing, palpitations, and leg swelling. He has no medical history and takes no medications. He denies substance use. His father died in a car accident when he was a young boy, and otherwise he is unsure of his family history. On examination, he is afebrile, heart rate is 85, respiratory rate is 16, blood pressure is 116/72, and oxygen saturation is 98%. On cardiovascular examination, S1 and S2 are normal. A 3 out of 6 crescendo-decrescendo systolic murmur is heard at the left lower sternal border that decreases in intensity with passive leg raise and sustained hand grip, and increases in intensity when he is asked to exhale forcefully while holding his nose and mouth tightly closed. The remainder of the physical examination is unremarkable. Electrocardiogram reveals T-wave inversions in the anterolateral leads. Echocardiogram is performed and reveals systolic anterior motion of the mitral valve. What is the best initial therapy for this patient? So I'd like you to pause the video for a moment and try to work through this question on your own first. All right, welcome back. So let's approach this question together. The first step is always going to be to read the actual question itself. What is this question asking me? So what is the best initial therapy for this patient? So as we're reading this, we know that this is going to be a question about management. And we glance at the answer choices and we see that some of them are medications, some of them are procedures, and they all seem to be either cardiac medications of some sort or cardiac procedures, which makes sense. We are clearly in a cardiology question, but it doesn't really give us much away in terms of how we're going to be thinking about this question. We just need to be thinking broadly here, knowing that these are either medications or procedures. So this is going to be a classic boards question where the first step is going to be to identify the diagnosis, and the second step will be to answer a specific question about the diagnosis. And the key point here is to notice that they're asking what the best initial therapy is. So this is going to be one of those questions where you need to know what you would do first as opposed to what all the correct answers are. And this clues us into there might be more than one correct answer in terms of possible interventions in this diagnosis, but that only one is going to be the best initial therapy. So pay close attention when you see these types of words, because you need to think about here is really specifically what is the best initial therapy. So now let's read from the top and highlight the key elements. So a 16-year-old boy presents to the physician's office complaining of fatigue, shortness of breath, and chest pain that occur during basketball practice. So these are exertional symptoms. He also experiences dizziness when he is exercising and has almost fainted several times during practice. So if I were to synthesize this sentence into one symptom, I would describe this as pre-syncope, right? The dizziness with exercising and almost fainting, that is the definition of pre-syncope. He denies cough, wheezing, palpitations, and leg swelling. He has no medical history and takes no medications. He denies substance use. His father died in a car accident when he was a young boy, and otherwise he is unsure of his family history. So summarizing the pertinent history here, this patient is presenting with exertional symptoms, including fatigue, shortness of breath, and chest pain, as well as pre-syncope, especially during exercise, with no other findings on review systems, and family history that is kind of a big question mark because we don't know exactly what happened here with this car accident. We'll talk more about that. On exam, he is afebrile, heart rate is 85, respiratory rate is 16, blood pressure is 116/72, and oxygen saturation is 98%. So those are fairly normal vital signs for 16-year-olds. I don't see anything there that jumps out at me as being abnormal. On cardiovascular examination, S1 and S2 are normal. A 3 out of 6 crescendo-decrescendo systolic murmur is heard at the left lower sternal border. So this is really where the money's going to be on this physical exam. It decreases in intensity with passive leg raise and sustained hand grip, and increases in intensity when he is asked to exhale forcefully while holding his breath or holding his nose and mouth tightly closed. So if we had to synthesize what maneuver this specifically was, this is what we would describe as a Valsalva maneuver. So you should be able to recognize sometimes the maneuvers or physical exam findings have special names, and you might know the name as a buzzword. But you also need to know the description of it because they won't specifically tell you that he is doing a Valsalva maneuver. They might say something like this, where he's exhaling forcefully while holding his nose, mouth tightly closed. So this description of the murmur is really going to be where the money is in terms of identifying what the underlying diagnosis is. So let's take a look at this murmur. So we're told it's 3 out of 6. It's crescendo-decrescendo, systolic, and it's at the left lower sternal border. So there's a lot to unpack here before we even get into the maneuvers. So 3 out of 6, we're starting to think that this is a little bit concerning here because any murmurs that are 3 out of 6 or louder are definitely concerning for being pathologic. Crescendo-decrescendo systolic murmur. Now, we've heard this term before. This is this is kind of the classic description of a few different types of murmurs. One of the more common ones being aortic stenosis. But it's not aortic stenosis. And why is it not aortic stenosis? Well, first of all, the age. The patient is definitely a little bit young, but he certainly is presenting with the exertional symptoms that we would expect to see in aortic stenosis. So this is commonly, they try to trick you and make you pick aortic stenosis because you see, oh yeah, crescendo to crescendo, I'm familiar with that. But pay attention to the details with the maneuvers because that's really what's going to help you differentiate this from the other murmurs. So it decreases in intensity with passive leg raise and sustained hand grip. So what do these things, what do these maneuvers do? So remember, passive leg raise is actually going to increase the venous return. So it's going to increase your preload, and sustained hand grip is actually going to increase your afterload. So both of these maneuvers are maneuvers that end up leaving more blood in the heart chamber. And then it increases in intensity with what we described as being Valsalva. And so Valsalva is going to decrease your preload. So this is a murmur that increases in intensity when there is less blood in the chamber and decreases in intensity when there's more blood in the chamber. So that might be a light bulb going off for you right now. If it's not, it's definitely a pattern that you should be able to recognize moving forward. So before we even get to the EKG and the echo findings, just the mere fact that this is a murmur that has these characteristics with these maneuvers should be a major clue of what's going on here. So do you remember what murmur this is? So this is the murmur for hypertrophic cardiomyopathy, and we'll review it in more detail in a moment. So then we keep reading. The remainder of the exam is normal. EKG reveals T-wave inversions in the anterolateral leads. Now, this is kind of an advanced finding, and we'll talk more about that. You don't need to know what it is to get this question right. It's there mainly to confuse you and to distract you from the meat of the question, which is really relies on your understanding of these maneuvers and how they affect the murmur intensity. So you don't even need to know what these refer to get this question correctly. Similarly, echocardiogram is performed and reveals systolic anterior motion of the mitral valve. So this is also there. It certainly helps with the diagnosis of HOCM, but you can answer the question without even understanding what this means. But this is here because it's also meant to help with the learning point of what is the underlying pathophysiology of HOCM, and so we'll come back to that in a moment. So let's review a little bit more about HOCM because there's a lot you need to know for the boards for this diagnosis. So hypertrophic cardiomyopathy. So clinical features, this is going to present with fatigue, dyspnea, chest pain, palpitations, pre-syncope, lightheadedness, even syncope, and classically these symptoms are exertional. So this really fits the presentation that this patient had. You might also get symptoms of heart failure, especially in more advanced disease, including orthopnea, paroxysmal nocturnal dyspnea, and lower extremity edema. But you don't necessarily have to have these heart failure symptoms. You could just have these pretty non-specific exertional symptoms of fatigue, dyspnea, chest pain, etc., the syncope. And these are also classically seen in aortic stenosis. So this is why these two diagnoses are commonly confused. On exam, you're classically going to have a crescendo-decrescendo systolic murmur at the left lower sternal border. And this murmur is caused by left ventricle outflow tract obstruction. So it's not an actual valvular problem. The underlying issue here is you get anterior systolic motion of the mitral valve leaflet that pushes against the interventricular septum and causes an obstruction of the left ventricle outflow tract. So that's why this location is a little bit unique in that it's not specifically corresponding to a specific valve, but it's corresponding to the left ventricle outflow tract. And it's really important for HOCM and for all your murmurs to understand your maneuvers and why the murmur increases or decreases in intensity. So in HOCM, the murmur will increase in intensity with all the maneuvers that decrease the amount of blood in the chamber. And the idea here is when you have less blood in the chamber, that anterior motion of the mitral valve, the mitral valve leaflet is more likely to be stuck against that interventricular septum and to cause that obstruction because there's not a lot of blood in the chamber to open up that outflow tract and to pull the anterior leaflet of the mitral valve away from the septum. So more blood in the chamber pulls those two apart, relieves the obstruction. Less blood in the chamber pushes them together. They kind of collapse against each other because there's nothing to keep them open. So any maneuver that decreases the amount of blood in the chambers, specifically in the left ventricle, is going to increase the intensity of your murmur. So Valsalva, abrupt standing, and nitroglycerin all decrease your preload, and so they're going to increase the intensity of the murmur. Conversely, the murmur will decrease in intensity when there's more blood in that left ventricle, more blood in the chamber. And so the things that can lead to having more blood in the chamber are either increased afterload, because if there's more afterload, it's harder for that blood to get out, and so more blood will be in the chamber. So sustained hand grip. Squatting can increase your afterload and your preload, so that's also going to increase the blood in the chamber. And then a passive leg raise will increase your preload, and so that will also increase your blood in the chamber. So all these things will kind of pull that anterior leaflet of the mitral valve off of the interventricular septum, and you'll have relief of that left ventricle outflow tract, and so the murmur will decrease in intensity. And finally, you may also get an S4 heart sound, and that's because of the heart hypertrophy, right? And so it's this stiff, non-compliant ventricle, and so you might hear an S3 as well. So in terms of diagnosis, on EKG, you'll classically see left ventricle hypertrophy, although in this question, they didn't give you that. They gave you the trickier finding, which is the presence of repolarization abnormalities. So these are classically T-wave inversions, especially in the anterolateral leads, 1 AVL, V4 through V6. Classically, you'll get T-wave inversions in those leads, and those are due to repolarization abnormalities that have to do with the hypertrophied ventricle. On echo, you're classically going to see left ventricle outflow tract obstruction, and again, this is due to the upper septal, interseptal hypertrophy and the systolic anterior motion of the mitral valve. And these are buzzwords for both either echo findings or pathophysiology that you should be familiar with and that you should be able to pick up on. They might not tell you that the septum is thickened, but they might tell you that there's anterior movement of the mitral valve, or they might even ask you what the underlying mechanism is for the murmur or for this lesion, and you should be able to pick this answer choice. So systolic anterior motion of the mitral valve, or anterior leaflet motion of the mitral valve, or something along those lines. You should be able to recognize that as being the underlying pathophysiology here. In terms of treatment, pharmacology is going to be the first line treatment for patients with symptomatic left ventricle outflow tract obstruction. So any of these symptoms are manifestations of the left ventricle outflow tract obstruction, and we're going to treat these symptoms pharmacologically. And so the mainstay, the first line initial treatment is going to be a beta blocker or a non-DHP calcium channel blocker, for example, verapamil. So beta blocker is the best choice. If that's not available, a non-DHP calcium channel blocker. And the way these work is that they work in a few different ways, but mainly they increase filling time during diastole because they slow down the heart rate. And by slowing down the heart rate, you're increasing filling time. And so by increasing filling time, again, you're ending up with more blood in the chamber. And so as we learned with the maneuvers, anything that leads to more blood in the chamber is going to relieve that obstruction because it pulls away that, that mitral valve anterior leaflet, pulls it away from the septum and relieves obstruction. They also work by reducing the myocardial oxygen consumption, and that can be one of the causes of chest pain in these patients, right? Because they have this thick hypertrophied heart that consumes more oxygen. So by reducing the heart rate, they're able to reduce myocardial oxygen consumption, and that can also lead to symptom relief. So this is commonly tested. This is high yields here. As are these maneuvers, very important to be able to recognize these and understand how they're different for hypertrophic cardiomyopathy compared to a lot of the other murmurs, which actually increase with intensity when you have more blood going across those valves. So this is actually the opposite of aortic stenosis. These findings are going to be the opposite in HOCM and aortic stenosis. So that's commonly tested. And then finally, you may get questions on genetics of this condition. So this is a genetic cardiomyopathy. Classically, it's mutations in the cardiac sarcomere. It's autosomal dominant inheritance. And the most common mutations are either in the cardiac myosin binding protein C and the beta myosin heavy chain. Kind of some more granular details, but if you're looking for that higher score, these are also worth memorizing. So I just want to point out one thing is that because this is autosomal dominant inheritance, there commonly will be a family member that had this. Now, they might not always say the family member had HOCM, but there might be a history of unexplained death in a patient of a young age, or often this presents with car accidents, where the patients ultimately die at the wheel and it ends up looking like a car accident, but it was actually because of sudden cardiac death that happened while the patient was driving. So look for unexplained causes of death in any family members, look for car accidents, or look for sudden cardiac death in any family members. That should clue you in because again, this autosomal dominant inheritance, you'll most likely have at least a family member affected, unless it's the first presenting mutation in the family, which is also possible. So now that we've learned all this really high yield information about HOCM, let's take a look at these answer choices and see if we can cross them out. So in terms of management, they're asking us again, what is the best initial therapy? So we already learned that this is going to be pharmacology is the best initial management of symptomatic HOCM, of that left outflow tract obstruction. So in terms of pharmacology, it's really going to be these first 4 options. The rest of these are procedures. So aortic valve replacement, that would be correct if this is aortic stenosis, but they're trying to trick you. This is not aortic stenosis, so cross that one out. Pacemaker and ICDs are not part of the initial management of HOCM. They might be in the more advanced stages, but certainly not the initial therapy. And then in terms of the medications, well, we learned that nitrates actually reduce your preload. So that would worsen your obstruction, right? Because you'll have less blood in the chamber, you'll have worse obstruction. So that one's clearly wrong. Amlodipine, this is here to trick you because you know that calcium channel blockers could be correct, but amlodipine is a DHP calcium channel blocker. And so the only ones that you can use in HOCM are the non-DHP, like verapamil. And so amlodipine is out. Non-DHP calcium channel blocker only. Furosemide, so this will lead to diuresis, also reducing your preload, and so that could also potentially worsen your obstruction because you have less blood, less circulating volume, and less blood in the chamber. So that one's out. And finally, we're left with propranolol. And so in terms of options, we know that beta blockers are going to be your first line pharmacology therapy for HOCM. And so this is the only beta blocker that we have available. And so answer D, propranolol, is the best answer here. So make sure that you have all of this information about hypertrophic cardiomyopathy memorized. This is a high yield topic, and they can test anything about the clinical features, the physical exam, especially the murmur maneuvers. They love to go after that, as well as the underlying pathophysiology and the management. All right, so that wraps up our question of the week. Thanks so much for listening.